Then I'll focus on head and spine, if time allows. So chapter 29 is chest injuries. Introduction. Each year in the United States, chest trauma causes more than 700,000 emergency department visits and 18,000 deaths. Chest injuries can involve the heart, lungs, and great vessels. It may be the result of blunt force trauma, or it can be penetrating trauma, or it can be a combination of both. Immediately treat injuries that interfere with normal breathing function. What does that mean? It means that if you are assessing your patient, you're assessing a patient, and upon assessing your breathing, you note that there is an injury to the chest that is affecting the patient's ability to breathe, then that injury needs to be managed in the primary assessment because it's affecting breathing. So this is a very important slide. So again, immediately treat injuries that interfere with normal breathing function. Internal bleeding can compress the lungs and it can compress the heart, and air may collect in the chest, preventing lung expansion. Let's review the anatomy and physiology. Remember the differences between ventilation and oxygenation. Ventilation is the mechanical action of breathing in and out. So it is the body's ability to move air in and out of the chest and lung tissue. Oxygenation is a process of delivering oxygen to the blood by diffusion from the alveoli following inhalation into the lungs. The chest or thoracic cage extends from the lower end of the neck to the diaphragm. Thoracic skin, muscles, and bones are located within this region. Similarities to other regions, also unique features to allow for ventilation, such as striated muscles. So the skeletal muscles, the intercostal muscles and the diaphragm are two very important muscles to the process of ventilation. Neurovascular bundle lies closely along the lowest margin of each rib. The pleura covers each lung and the thoracic cavity. A small amount of pleural fluid between the parietal and visceral pleura allows the lungs to move freely against the inner chest wall during respiration. So just below the margin of the rib, you have neurovascular bundle, blood vessels and nerves that supply that area. The pleural membrane is a membrane around the lung. It has an inner lining and an outer lining. These are things we have learned before. The lining that attaches directly to the lung is the visceral pleura. That's the one that directly attaches to the lung. And the parietal pleura attaches to the chest cavity. And there is fluid within that space to prevent friction, and it can become a potential space if an injury occurs and air or blood is accumulating in that area. Vital organs such as the heart are protected by the ribs, connected in the back to the vertebrae and connected in the front to the sternum. The mediastinum contains the heart, so that's the space between the lungs. The mediastinum contains the heart, great vessels, esophagus, and trachea. A thoracic aortic dissection can develop in this area of the chest. The diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. And when a patient or an individual exhales, the diaphragm can come as high as the nipple line. So it can reach as high as the nipple line. With that understanding in mind, if you're going to be assessing a patient's chest, you need to be thinking about the upper abdomen as well. And if you're assessing the upper abdomen, you need to be thinking about chest. Mechanics of ventilation. The intercostal muscles between the ribs contract during inhalation because this is the active phase of breathing. The diaphragm contracts at the same time. So during the active phase, muscles contract. During the passive phase, which is exhalation, muscles will relax. So the intercostal muscles and the diaphragm relax during exhalation. During the inhalation phase, negative pressure is created inside the lungs or thoracic cavity. And during exhalation, positive pressure is created. The body should not have to work to breathe when in a resting state. No, patients with spinal injury below C5. Well, the first thing is to note is if the spinal injury is between C3 and C5, the patient can lose their ability to ventilate. So between C3 and C5, the phrenic nerve originates, and that goes to the diaphragm. So between C3 and C5, that keeps the diaphragm alive. So if the injury is below C5, they can still use the diaphragm. Patients with a spinal injury above may lose their ability to breathe. So if it's above C3 or between C3 and C5, they can lose their ability to ventilate. And the patient can have quadriplegia, hemiplegia, and paraplegia. We'll look at that when we cover spinal injuries more closely. Quadriplegia would be all four quadrants, right? The limbs, upper limbs, lower limbs. So that's paralysis from the shoulder down. Hemiplegia, half of the body is paralyzed. And paraplegia, the lower portion of the body is paralyzed. Minute ventilation or minute volume. The amount of air moved through the lungs in 1 minute. Normal tidal volume times respiratory rate will give you your minute volume. Patients with a decreased tidal volume will have an increased respiratory rate. So if the chest rise becomes poor, the breathing rate goes up to try and compensate for that. If it's not able to compensate for that, eventually it's going to come back down and the patient stops breathing. Injuries of the chest. So there are two types of open two types of chest injuries: open and close. In a closed chest injury, the skin is not broken, and it is usually caused from blunt trauma. Closed chest injury can cause significant cardiac and pulmonary bruising. So it can bruise the heart muscle and it can bruise the lungs. If the heart is damaged, it may not be able to fill effectively. And if it cannot fill effectively, it cannot contract effectively. So cardiac output would be reduced. Lung tissue bruising can result in exponential loss of surface area. Rib fractures may cause further damage. Now, in an open chest injury, an object penetrates the chest wall itself. It can be a knife, can be a bullet, can be a piece of metal, a broken end of a fractured rib. Do not attempt to move or remove the object unless, and we know the circumstances in which we would remove an impaled object from the chest. It must interfere with where we would need to put the palms of the hand to do chest compression. Blunt trauma to the chest may cause rib, sternum, and chest wall fractures. Bruising of the lungs and the heart can cause damage to the aorta, and vital organs can be torn or partially torn from their attachment in the chest cavity. Signs and symptoms that you need to look out for. Patient is going to have pain at the site of injury. It can be aggravated by bleeding. So usually patients with chest injuries that are responsive and breathing, they tend to breathe shallow. That reduces the pain and discomfort. So bruising to the chest wall may be observed. Crepitation or crepitus with palpation of the chest. That's the bone ends rubbing together under the skin. They can also have subcutaneous emphysema, penetrating injury to the chest, and they can definitely gonna have difficulty breathing. They will present with hemoptysis. If they are coughing up blood, that's hemoptysis. They're coughing up blood, it's coming from the lungs. They're vomiting up blood, it's coming from the intestines. They can have failure of one or both sides of the chest to expand normally with inspiration. So they can have reduced chest rise on one side, which is what we would refer to as asymmetrical movement of the chest. It's not symmetrical. They can also have paradoxical motion, where one side of the chest is going out while another side is going in. So it's moving the opposite of normal. Can have rapid weak pulse and low blood pressure, cyanosis around the lips and fingernails. Chest injury patients often have rapid, shallow respirations because it hurts to take a deep breath, and the patient may not be moving air appropriately. Auscultate multiple locations to assess for adequate breath sounds. So you need to ensure that you listen to their lung sounds early. Patient assessment. Now in the patient assessment, starting off with a scene size up, scene safety. Ensure the scene is safe for you, your partner, your patient, and bystanders. And I would put my unit before bystanders. If the area is a crime scene, do not disturb evidence if possible. Request law enforcement. For scenes involving violence, use glove, eye protection. Mechanism of injury. Chest injuries are common in motor vehicle crashes, falls, industrial accidents, and assaults. Determine how many patients you have. If you have more than one patient, more than one patient present, do you have the relevant resources necessary to deal with this situation? If not, then you might have a mass casualty situation on your hands, and this is where you start to think about requesting other units and the whole triage process. Consider spinal immobilization or spinal motion restriction. After you have completed your scene size up, the next phase of your assessment is your primary assessment. You form a general impression of the patient and the environment. So form a general impression. If life-threatening hemorrhage is present, address it immediately. Note the patient's level of consciousness. Perform a rapid physical examination. Obvious injuries, appearance of blood, difficulty and irregular breathing, cyanosis. Chest rise and fall only on one side. Accessory muscle use, extended or engorge jugular veins. These are things that should be a red flag for you. Assess the ABCs, assess overall appearance. So after you have assessed the patient's level of consciousness and you have assessed the upper airway, the next phase is to assess the upper airway and the lower airway and manage appropriately. So ensure that the patient has a clear and patent airway. Consider early cervical spine stabilization if appropriate. Are jugular veins distended? And there are a couple conditions that can cause the jugular veins to become distended. Is breathing present and adequate? Perform your decap BTLS IC. Look for equal expansion of the chest wall. Check for paradoxical motion. That's when one side of the chest is moving the opposite of normal. Asymmetrical is when both sides not rising together. Apply occlusive dressing to all penetrating injuries, especially to the chest, anterior and posterior, and upper abdomen. So if it's a puncture wound to the upper abdomen, then consider putting on a occlusive dressing. Support ventilations as needed. Reassess the effectiveness of ventilatory support. Be alert for decreasing oxygen saturation. Be alert for impending tension pneumothorax. After we have done our assessment and management for A and B, next it's circulation. In your circulation, check pulse rate and quality. Patient talking to you, peripheral pulse. Not talking, central. Look at the skin color and temperature. If you see changes peripherally for skin color, check for changes centrally. Address life-threatening bleeding immediately using direct pressure and bulky dressing or any other dressing that you think is appropriate. After we have completed the ABCs, LOC, airway, breathing, circulation, at this point you should know what your patient's GCS is. You should know if you need to do a rapid scan or a focus, and you should know if it's a load and go or stay and play patient. So transport decision. Priority patients are those with a problem with their airway, breathing, and circulation. Pay attention to subtle clues. How does the skin look to you? What is the patient's level of consciousness? Is there an impending sense of doom? So does the patient tell you that they feel like they're not gonna make it? Feel like I'm gonna die, man. Something ain't right. Now, there are something, this table represents the deadly dozen as it relates to chest injuries. So these are the 12 complications that can kill a patient if present. So number 1, airway obstruction. 2, bronchial disruption. 3, diaphragmatic tear. 4, esophageal injury. 5, open pneumothorax. 6, tension. 7, massive hemothorax. 8, a flail chest. 9, a cardiac tamponade. 10, thoracic aortic dissection. 11, myocardial contusion, and 12, a pulmonary contusion. Number 1 is airway obstruction. After we have completed the primary assessment, next is history taking. Once a patient is talking to you, history, then we move into the secondary. They're not talking to you, vital signs. Try and get information from persons on location and consider the physical findings. So history taking, investigate the chief complaint, further investigate the MOI, identify signs and symptoms and your pertinent negatives. Obtain a sample history, a basic evaluation should be completed, and you focus on the MOI. Once we have completed the history taking phase, next is secondary assessment. Physical examination should include, for an isolated injury, focus on the isolated injury, the patient's complaint, the body region affected, location and extent of injury, anterior and posterior aspects of the chest wall, and changes in respiration. For significant trauma, likely affecting multiple systems, start with a rapid physical examination. Use your DCAP BTLS IC to determine the nature and extent of the injury. Vital signs, we want to consider the patient's level of consciousness, pupil reaction, respiration with pulse oximetry, end-tidal CO2 if available, pulse, blood pressure, blood sugar. Vital signs, assess pulse, respiration, blood pressure, skin condition, and pupils. Reevaluate every 5 minutes or less. Pulse and respiratory rates may decrease in later stages of the chest injury. In your reassessment, you're repeating your primary assessment. Reassess the chief complaint, reevaluate airway breathing, circulation, and bleeding control. Interventions, reassess vital signs and observe for trends. Is your patient trending up or down, or is the patient stable? Provide appropriate spinal stabilization or spinal motion restriction when it is indicated. Maintain a patent airway, control significant or visible bleeding, place an occlusive dressing over penetrating trauma to the chest wall. For patients with signs of hypoperfusion, provide aggressive treatment for shock and rapid transport. Do not delay transport to complete non-life-saving treatments. Communicate all relevant information to the staff at the receiving hospital. Now let's look at issues. First one, pneumothorax. A pneumothorax is commonly referred to as a collapsed lung. And what it is the accumulation of air in the pleural space. Blood passing through the collapsed portion of the lungs is not properly oxygenated. You may hear diminished or absent or abnormal breath sounds on the affected side. So that's a pneumothorax. And this is what it looks like. Now, an open chest wound, often called an open pneumothorax, or sucking chest wound is a wound to the chest in which the pleural membrane is ruptured and the air gets into the pleural space and collapses the lungs. It's an open wound, so the risk for tension pneumothorax developing is not high because there's an opening. Wounds, a sucking chest wound must be sealed with an occlusive dressing, and we're sealing 4 sides. Now you have commercial type occlusive dressings that have a flutter valve, so you don't have to tape it. You actually just remove it from the seal and put it on the area, and it has a flutter valve on it, a commercial type. You don't have a commercial type, a simple piece of plastic can be used as a occlusive dressing. The plastic that you keep your oxygen mask in, you can cut that and turn it into an occlusive dressing. You just need an airtight seal. Carefully monitor the patient for tension. These patients are not at a high risk for tension. They can have trapped air, and they start to show signs of a tension. If that occurs, you simply burp the dressing. We call it burping the dressing. So you slide a finger underneath the dressing and just lift it up to release the pressure that's building up. Now, a simple pneumothorax. A simple pneumothorax does not result in major changes in the patient cardiac physiology. So you're not going to see a lot of circulatory issues with a simple pneumothorax. It's common due to blunt trauma that results in fractured ribs. Can often worsen or deteriorate into a tension pneumothorax or develop complications. So once it's blunt force trauma that has caused the rib fracture, there is no longer an opening for the air to escape. So that's a patient who is going to be at a high risk for developing a tension pneumothorax. So you need to pay closer attention to their lung sounds and what their cardiovascular assessment is depicting. Now the tension pneumothorax result from ongoing air accumulation in the pleural space. So the pressure that is building up in the pleural space that is collapsing the lungs, it is causing the pleural membrane to expand to the point that it starts to obstruct the movement of the heart. And that can affect cardiac output and cause obstructive shock. So this is a life-threatening issue. So increased pressure in the chest causes complete collapse of the unaffected lung. The mediastinum is pushed into the opposite pleural cavity. Commonly caused by blunt injury, where a fractured rib lacerates a lung or bronchus. Right, so this diagram is depicting a tension. And if you look closely on this diagram, you can see where the trachea actually starts to shift, which is a late finding, right? Because it's compressing the heart, there's going to be back pressure in the blood vessels. So you'll definitely see some distended neck vein in these patients. Hemothorax. Now, a hemothorax pathophysiology is similar to the pneumothorax. The difference is it's no longer air. It's no longer air accumulating in the pleural space. It is blood accumulating in the pleural space. Right? So the problem is blood. So blood collects in the pleural space from bleeding around the rib cage or from a lung or great vessel. So at the top is a hemothorax. At the bottom is a pneumothorax. That patient actually has a combination of air and oxygen. Sorry, a combination of air and blood accumulating in the pleural space. Signs and symptoms for hemothorax: shock without any obvious external bleeding or apparent reason for shock, decreased breath sounds on the affected side, pre-hospital treatment, rapid transport. So manage your ABCs, rapid transport. Pneumothorax, the presence of air and blood in the pleural space. Now the cardiac tamponade. The protective membrane, the pericardium, around the heart fills with blood or fluid. The heart cannot pump an adequate amount of blood. Right? So eventually the blood or fluid will create pressure on the heart. The heart doesn't have the room to expand, to fill with blood and contract, so that can create back pressure in the neck veins. Signs and symptoms: Beck's triad, and altered mental status. Beck's triad is distended neck veins, muffled heart sounds, low blood pressure, or emerging pulse pressure. Pre-hospital treatment, support ventilation, rapidly transport. Rib fractures, common particularly in older people and persons in full contact sports. A fracture of one of the upper four ribs is a sign of a very substantial MOI. Remember that the first 7 are your true ribs, so they are directly attached to the sternum. So if the first 4 is fractured, it takes a lot of force to break that. A fractured rib may cause a pneumothorax, can cause a hemothorax, and it can cause a hemopneumothorax. Signs and symptoms: localized tenderness and pain when breathing, rapid, shallow respirations, patients holding the affected portion of the rib cage. Pre-hospital treatment must include or should include supplemental oxygen administration. Now, a flail segment, which is depicted on this diagram. A flail segment is when more than one ribs are fractured in more than one place. And where the fractures are, that segment is completely detached from the rib cage. So it's no longer attached to the rib cage. Because it is no longer attached to the rib cage, when the patient breathes in, that segment moves in. When the patient breathes out, that segment moves out, which is the opposite of normal breathing. So normally when we breathe in, the rib cage moves out. When we breathe out, the rib cage moves in. Now, can anybody tell me why the flail segment is moving the opposite of normal? So why is it that the flail segment is moving the opposite of normal? Does anybody know the answer to that question? Nobody has any thoughts on that? Okay. we'll leave that for tomorrow. So the flail chest is caused by compound rib fractures that detach a segment of the chest wall. The detached portion moves the opposite of normal, and your homework is to find out why it is moving the opposite of normal. Make sure you have a response for me tomorrow morning. Flail chest. Pre-hospital treatment, maintain the airway, provide respiratory support if needed, give supplemental oxygen, perform ongoing assessments for complications. The best way to manage a failed segment is to take control of the patient's ventilation. That's the best treatment approach, to take over the patient's ventilation. Treatment may include positive pressure ventilation with a bag valve mask, and that's the first line treatment. That's the best thing you can do, to take over the patient's ventilation. Restricting chest wall movement is no longer recommended. So in the past, we used to use bulky dressing to keep the segment down. That's no longer done. So that's not practiced in EMS anymore. Flail chest may indicate serious internal damage or spinal injury. Other chest injuries, pulmonary contusion, should always be suspected in a patient with a flail chest. Pulmonary alveoli becomes filled with blood, leading to hypoxia. Pre-hospital treatment, supplemental oxygen, positive pressure ventilation as needed. Other fractures, sternal fractures, create an increased index of suspicion for organ injury. It takes a lot of force to fracture the sternum, so you should definitely be thinking about internal damage. Clavicular fractures, possible damage to the neurovascular bundle can occur. Suspect upper rib fractures in medial clavicular fractures and be alert to pneumothorax development. Traumatic asphyxia. Now, traumatic asphyxia or traumatic asphyxiation is when something falls on the patient's chest. So something is crushing the patient's chest. And if something is crushing the chest, it's going to affect the circulation of blood. So there's massive back pressure that's created. This patient will have distended neck veins. The pressure can be so extreme that it can rupture blood vessels in the eyes. So they will have hemorrhage in the sclera of the eye. And traumatic asphyxiation is basically suffocation. They won't be able to breathe properly, any at all. It can also develop from position, the position that the patient in. So a patient can have positional asphyxiation as well. So a sudden severe compression of the chest suggests an underlying injury to the heart and possibly pulmonary contusion. Pre-hospital treatment, patient is going to require aggressive airway management. Ventilatory support and supplemental oxygen. Monitor vital signs during immediate transport. Blunt myocardial injury, bruising of the heart muscle. The heart may be unable to maintain adequate blood pressure. One of the key signs you will find with a heart that is bruised is an irregular pulse rate. Patient will have chest pain or discomfort. Suspect it in all cases of severe blunt injury to the chest. Your pre-hospital treatment, carefully monitor the pulse, note changes in blood pressure, provide supplemental oxygen, and transport immediately. commotio cordis. Now, commotio cordis is when a patient gets a blow to the chest. So there is blunt force trauma to the chest, but at the point that the blow is delivered to the chest, the ventricles are filling with blood. So when they get that blow to the chest, it disrupts the force is transferred to the ventricle, and it disrupts the electrical impulses within the heart, and the patient immediately collapse. So they collapse and go into cardiac arrest. This is seen in sports where there is a lot of contact: football, rugby, American football, martial arts tournaments, right? And it could very well be where the legend behind the dead touch originated from. There's no dead touch, but if you're hit dead center in the chest, close to the left side, at a point when your heart is about to fill with blood, it can actually disrupt the electrical function of the heart, and the patient goes into cardiac arrest. Ventricular fibrillation responds positively to defibrillation within the first 2 minutes of the injury. Laceration of great vessels may result in rapidly fatal hemorrhage, pre-hospital treatment, cardiopulmonary resuscitation, ventilatory support, and supplemental oxygen if needed, immediate transport, be alert for shock, monitor for changes in the baseline vital signs. That would be the end of injuries to the chest. Not a long chapter. Question 1, if you're present.